Hi, everyone, and welcome back to the Modern Spirit Podcast, a show dedicated to demonstrating the value of spiritual healing in modern healthcare. I'm Natasha Pentin, today's co-host, and I come from a journalism and PR background with experience across NGOs, sustainable development, plant medicine, and breathwork. And the other co-host is Dr. Joe Tafur, who is an integrative family physician and co-founder of Modern Spirit. And today we're going to be speaking to Dr. Evan Cole-Lewis, who's a Canadian adult and pediatric neurologist with specialized training in epilepsy and pediatric neurology. He holds a clinical appointment as Adjunct Assistant Professor in the Department of Pediatrics at the Hospital for Sick Children and at the University of Toronto. From 2016 to 2024, Dr. Lewis founded and led the Neurology Centre of Toronto. He also served as Vice President of Psychedelic Neurology at Numinous. Currently, he's practicing at North Toronto Neurology and Homeward Therapy, and he's focusing on epilepsy, brain injury, concussion, post-concussion symptoms, functional neurological disorders, particularly functional seizures, and the therapeutic use of cannabis and psychedelics for these conditions. He's also helped edit a new textbook about real-world medical cannabis prescribing, which has just come out. So there'll be more information about this at the end of the podcast. So Evan, welcome. Thank you so much for being here.
Thanks, Natasha, and thanks for the nice introduction.
So Joe and Evan, maybe you'd like to start off just by how you both met. And you both just spoke at the WeCann conference in Brazil. So maybe about your experience there.
I met Evan because I had this crazy flight from the Brazilians. They sent me from Phoenix to Toronto and to go to Sao Paulo, Brazil. So it was a very long journey. I was like, why am I doing this? But then I end up in the shuttle with Evan. It's a 90-minute ride from the airport to Campinas, where we went to the WeCann conference, a medical doctor cannabis conference. And so then, we had all this time to talk, but then I was very impressed and interested in a lot of Evan's ideas that he's, we're going to get a little bit into this cannabis history, but then also getting to the psychedelic work eventually and the overlap between a lot of things that I am interested in. And then also medically speaking, just this whole new kind of framework coming out of the neurology kind of lens that is opening a new door, I think, for me in this like trans diagnostic, when we see how the psychedelics are working on this problem and that problem and this kind of what's linking these problems, and we're trying to understand that together. And we know there's emotional stuff and psychological stuff, and there's physical stuff, and now we're learning more and more about network issues. So I guess we'll start asking you, Evan, about, you told me a little bit about how you, as a pediatric neurologist working with, epileptic seizures and kids or seizures in general with youth and with the psychedelic work where there's this stigma and a way of getting involved. But then with cannabis, I think, here I had a very close friend it's a child with really serious seizures, and you're just like, hey, why don't you try the cannabis? And they're not quite ready for it and they don't know. And then you hear these at WeCann conference. Whoa, this is really making a difference for some people. Maybe you can tell us a little bit about how you got connected to that and what you observed.
Yeah, sure. I remember our car ride, Joe. That was 90 minutes. It was great talking to you because I think we talked the entire time. After coming off that really long flight, I think my Garmin said I had about 2.5 hours of sleep on that plane that night.
Yeah,
so it was
exactly.
it was great. It was a great conversation, and I'm here now, so it's a pleasure to be here with you and Natasha too. So for me, I'm by training, I'm a pediatric neurologist, and then went into subspecialty epilepsy training. And it was just at that time when cannabis was emerging as a potential treatment. It was prior to the big Epidiolex trials that occurred in the States, which ultimately has led to Epidiolex, a CBD isolate medicine, being approved. But it was kind of like right at the cusp of that happening. So it was a really interesting time because there was a significant movement from the grassroots, from the parents of a lot of these people and patients themselves, adult patients too, but it hadn't really broken through into the field of neurology or medicine at any kind of substantial amount. So we would, when I was a resident training in Ottawa, I followed one patient who had a really serious epileptic syndrome called Dravet syndrome, where these children present with terrible seizures and they're drug resistant and have a really bad prognosis overall because it's very difficult to get a hold of the seizures. And one of the patients in my longitudinal clinic was a boy with Dravet syndrome. And at that time, the mother had come to the group and said, hey, I really want to use cannabis. I'm hearing all these things about it. And it was dismissed overall. I mean, we had no safety data, as I said, at that time. We're talking about 2009, people didn't know much. So I was intrigued by the fact that people were talking about cannabis, but outside of that, I didn't think much more of it. But she kept on coming back. And anyway, flash forward a couple of years, I end up in Miami doing my epilepsy fellowship. And I come home that Christmas, and on the second page of the National Post, I think it was, or one of the national newspapers in Canada, there's my patient who I was following for all these years who never responded to any medication. And there was an article about him, and he was seizure-free from cannabis. And I could, this boy was having multiple seizures a week. And that was, I mean, at that point, I'd already had been moving a little bit towards being skeptical. I was skeptical about, did cannabis doesn't work, and it's, and all. I was kind of more very intrigued about it, and this was the straw that broke the camel's back. At that point, I said, okay, we just don't know everything, and and our mentors, right, are also confined by the knowledge of their mentors, et cetera, et cetera. So that was it for me. And at the time when I was training in Miami was ready to be a site for the Epidiolex trials. So that's when I started to get into cannabis more seriously, started to explore it, and basically self-taught at that point because there was nobody to teach us about this. And that was the case that kind of broke through for me. And when I came back to Toronto, I trained at SickKids for a little bit and ultimately opened up my own clinic. And one of the main purposes of that clinic was to treat children with cannabis for their epilepsy. And so it just kind of happened a little bit organically. And then ultimately being in that space at that time, psychedelics intersected, and you couldn't help but start to read about psychedelics as well. And my mind was already open at that point in time. So I was very open to the idea that psychedelics could, treat various different disorders.
The one thing I want to just to flesh it out for the people. So Epidiolex is CBD. It's a pharmaceutical grade CBD.
Correct. Yeah. So Epidiolex is a medication. It's FDA approved. It's also approved in Europe, and it was recently approved in Canada. So essentially, it's plant derived, but the CBD is extracted. So all the other components are washed out of it, more or less. It's something like 98 or 99% CBD with a little tiny bit of other plant components in it, but they're negligible. So yes, it's pretty much almost 100% CBD plus other components that keep the oil stable. And so yes, it's purified CBD, and therefore that's why I was able to get FDA approval, because it's a single drug versus when you're dealing with cannabis. Otherwise, you have all the components, and it's very hard to put through RCTs consistently. And this is why we don't have any other significant cannabis products that are approved, and none for epilepsy outside of Epidiolex.
My question to follow up about that was that was a really touching story, but I would love to hear more about your personal experience and your success stories and what happened since then, since kind of that euphoric moment where you went, okay, now I really know where I want my focus to be. So the real success stories maybe that you could share with us, but also perhaps you're speaking about children here as well. So any of the pushback that you faced at the same time.
Yeah. There's a little bit more to this story, as you've alluded to here, Natasha, in terms of kind of my own experience with my own patients at that point. So around 2014, I come back and I complete my fellowship at SickKids, and then I worked at SickKids Hospital in Toronto for a year and a bit. And at that time, because I was so interested in cannabis, it came to be that parents started to know that I was interested in it. So parents would come to the hospital, and at that time, nobody would manage cannabis, nobody's prescribing it, especially for children. And, we'd go in and see patients, then everybody would leave, and parents would come up and say, "Are you Dr. Lewis?" And I say, "Yes." And like, "Can you help us with our cannabis treatment?" Right? And it's only because I just knew about it and would talk to people about it, essentially, where others I don't think would really have that big of a conversation, or maybe perhaps they weren't equipped. I don't know, but I would very openly have those conversations. And as I started to develop more about like a harm reduction type model of care, knowing that these, in Canada at that time, you could access it. So I knew parents were going to access it anyway. So fast forwarding a little bit, I left sick kids, opened up my clinic. And again, one of the impetus for that was to treat pediatric epilepsy and adults as well. So I do treat adults too. And at that point, I was managing cases and hadn't really prescribed because it was challenging to do that back then. And then at one point, I started to do that. But then I had one case in particular, two actually. They were similar cases of kids that just had really horrible seizures. Nothing worked. And then I said, okay, I guess I'm going to try cannabis and with THC in it. And this was quite controversial at that time. And it was around New Year's. We tried it on this one patient. And I remember getting the text from mom a couple of days after, and she said, she's seizure free. And it was the first time this child was seizure free for a whole year. And this was a 2-year-old who was perfectly healthy prior to that. And at the same time, there was another 12-year-old I was treating. She too became seizure free. So these were both kids that had horrible seizures for years in really critical points of their brain development. And we were able to quiet that down and put their brain into a state of normal function, which is really important at that time to allow and permit normal brain development. I still get shivers even telling you guys about that case.
So did I.
Yeah, and it was just like at that time, it was so unbelievable that this would happen for those kids. And again, it's not in every child, but these were like two really prominent cases. And so those were the kind of two origin kind of success stories, I think, for me for cannabis and epilepsy. And then from there, I really started to develop protocols for other conditions in neurology like autism, sleep disturbance, headaches, post-concussion symptoms, and a variety of other conditions. Becoming familiar with cannabis and realizing, its risks and its safety parameters and being comfortable with it, I was able to do that. So that was kind of on the cannabis side. The psychedelic side has some other interesting success.
I just had one other question there before we do get kind of into the psychedelic space, but do you also find that these treatments are sustainable, like long-term? Have you found that the seizures haven't come back, like long-term, they are sustaining their impact?
So I think it raises a really important point. So in the end, kind of stepping back from, these types of kind of really special success stories, to put this in the proper context is in the end, when the dust, settles, cannabis is just an epilepsy medication, right? But what's unique about it is that it's an epilepsy medication that works via a unique mechanism that we do not have in our other anti-epileptic drugs. So when you kind of look at it, epilepsy is a complex condition, and there are many different causes for people to have seizures. And so it seems like a proportion of individuals, children and adults, have epilepsy due to dysfunction in the endocannabinoid system. Therefore, if you use cannabis, you can recalibrate or rebalance the endocannabinoid system and thus stop the seizures. So it doesn't work in everybody, but it works in some people who clearly have seizures due to endocannabinoid dysfunction, because when you give them cannabis, their seizures go away, but when you give them other medications, that doesn't happen. Likewise, we have other epilepsies where you give medications that impact the systems that are affected. So a nice example is absence epilepsy. This pathway is well known, and 90% of kids respond to a particular medication that blocks calcium channels. So we know the mechanism here. So if you give that medicine 90% of the time, you're going to do it. If you give cannabis, it's not going to work in those kids. So that's a really important point. So to answer a question about sustainability, if cannabis is used in a child or an adult and they respond robustly, like the cases I told you, right, then it's sustainable. So in the cases I just mentioned to you, we got rid of the other drugs. There, in many cases, I have many cases like this now where they're only using cannabis, but that's no different than the absence seizure where they would be only using ethosuximide, that drug that works in that one. So I don't look at it as being kind of special or prominent. I look at it as an epilepsy drug. And if you really understand the mechanics of epilepsy, then you know that it's going to work and be sustained in a subset of kids and adults.
Right. I think it's kind of transitions over because we're talking about these different And that was a big theme at the conference is, okay, this endocannabinoid system in the brain, right? That it doesn't get enough attention in Western medicine. But then as and like you said, you've been dealing with the seizures and the non-epileptic seizures and the headaches and post-traumatic headaches, and studying, distinguishing different kinds of problems from a neurology perspective and looking for solutions for people that respond to this and don't respond to that. I mean, somewhere along the lines, you got into psychedelics. How did that happen?
Yeah. So as I was combing the literature to try to figure out this cannabis stuff at the time, I remember specifically the day this happened. It's like up on it may have been PubMed or something popped up this article, and the title caught my eye, and the title was something along the lines of LSD improved quality of life in palliative individuals due to cancer or something, right? So I was like, LSD? What? LSD? And I was like, really? Do they mean acid?
Yeah.
Right? I was like, no, this must be right. So I open up the article and I read the article. The 2014 article by Gasser, I think. Anyway, and it was a crossover study of two groups of individuals with cancer who were palliative. And in both treatment groups, they had like 80% better quality of life. And I was like, what? Honestly, improve quality of life in people with palliative care. Now, the big kind of neat thing there is that this was my thing with epilepsy. Like very rarely in the drug-resistant epilepsies do people come back and do they tell you their seizures got better when they try something, right? So a lot of people are skeptical about epilepsy. And in working with cannabis, and it was really strange, saying like, oh, it can't work, but people don't come back and tell you the seizures got better when they take something. Like that just doesn't get reported. It's a weird thing. So the people who were denying it at the time, there was always an odd reaction to me. It's like, oh, the parents are making it up. And it's like, no, I mean, that doesn't happen. So same with this. It's like people who are dying and take something aren't going to lie to you and tell you that they're better, right? So for me, it was like, this is legitimate. And that was it. I started to look into psychedelics because the same kind of mentality about cannabis. And then I just did a massive deep dive, completely self-taught, started to learn from a lot of experts in the field who were there as well, utilizing YouTube, going to conferences and meetings, and started to piece together the concept of how psychedelics are working at the neurological level. And at the same time, started to explore the area of functional neurological disorder. And then looking at the cause of functional neurological disorder, which is essentially brain network abnormalities, and then looking at psychedelics, seeing that they act on brain networks, it just it makes sense to me, and still to this day, it's one of the most elegant kind of intersections. Is that psychedelics to me are certainly a treatment for functional neurological disorder, and that's been the bulk of my research and work in clinical practice in that area right now.
Maybe we can break down an example for people. So I think the post-concussive like headache thing is it like that's interesting. And then maybe you can relate it also to the non-epileptic seizure to help people. Okay, what is a network disturbance? What does that mean? Like a patient that's going to the doctor and you say, well, it's a network disturbance versus what, physical or whatever they think it might be. And then so identifying that, and then maybe if you had so I imagine this is with ketamine that you're working with these people. So like an example, somebody that oh, wow, look what we just, were you able to shift something? Now we're not talking just about seizure treatment and pharmacologic support, but like, oh, were we able to correct something?
Yeah, I think, look, it's a really hard topic to talk about FND. However, it's emerging and more people are understanding this. It's a hard thing to kind of wrap your head around if it's never been something that you've thought about or conceived of before. But I think most people have had, especially clinicians, certainly have had experience with this, whether they saw it or not. So I think the first thing to do is just unpack what FND is. And a good example, really, one of the more straightforward examples is something like looking at what you've mentioned, functional seizures. So up until this point, we were talking about epileptic seizures, and those are the seizures that we utilize cannabis to treat. And so the question is like, what is epileptic seizures? Well, one really easy way to conceive of epileptic seizures is they're electrical seizures. So it's when the electrical activity in the brain is not working properly. It's abnormal. So what you do is you use medications to re-regulate the electricity. So if you have an electrical problem in the brain, Those are epileptic seizures, and you use treatments directed at regulating electricity. Then you have this whole other category of non-epileptic seizures. So these are seizures that look exactly like epileptic seizures or very similar or have similar features, but they also have their own features as well. And these, again, classified as non-epileptic, you can think these are non-electrical seizures. So if someone is having one of these seizures and you put an EEG on them, so an EEG is a tool that measures electrical activity of the brain. If we do that with people who have these non-epileptic seizures, these non-electrical seizures, the EEG is normal. It doesn't change. You don't have the same electrical problem. So if you treat with electrical medicines, the anti-seizure drugs, it doesn't work because it's not an electrical problem. So then that begs the question, well, where is this problem? And this has been a mystery for a long time, but has begun to be unpacked over the last couple of decades. And now there's really good developing models and theories. So the idea is that these seizures are due to problems in how the brain is functioning, the function of the brain as a whole, as an integrated whole. And how the brain operates is via brain networks, how the brain is connected. So if you get abnormalities in brain connections, brain networks, you can have expressions of certain things like seizures, where in that case, then, if I take a picture of the brain looks normal. If I test the nerves in the body, they're all normal. So these speak more to abnormalities in brain function that we would have to use imaging like functional MRIs or functional scans, brain scans that tell us about the brain's function, and then we can use that to diagnose these types of things. So it's kind of like the first part of it, because it's a complicated,
Right.
but that's the first introduction to separate these things out. I'll say one more thing and I'll turn it over to you guys. So seizures is a good example, but there's okay, so then you just expand that into any other neurological expression. So something like an arm that's paralyzed. So an arm can be paralyzed from a structural problem in the brain, like a stroke. You can have a stroke in the area that controls your arm, and then the structure of that part of the brain is disrupted, and therefore you will not move your arm. But there's software in your brain. The way it's networked sends signals that is a program on how you move your arm. This is like, you just move your arm. You don't know how you move your arm. You just move it, right? So it requires the structure, but it also requires the ability for the brain to move the arm, the function. So what we now know is you can have structure problems like a stroke that can cause you to paralyze your arm, but you can also have primarily functional problems that will also paralyze your arm. And so what we might see, and what you might see in practice, is someone walks in and something happened to them. There's typically an event and they can't move their arm. But you do an MRI and everything's normal. You do the nerve test, everything's normal. They still can't move their arm, right? But if we were then to do things like functional MRI, or if we were to do physical exam maneuvers to pull out functional problems, you can pick this out and you can see that this is a problem with the functioning of the brain, the functioning of the programs that control the arm, rather than the structure itself. Yeah, that would be FND. Mm-hmm.
And how easy or how quickly would a doctor, for example, decide that a certain patient deserves to get this functional MRI imaging? Just because, there may be people that for years have been thinking, I've definitely got something wrong, but I just can't get to the bottom of it, and the doctors aren't doing the right test. So how do you know to test for this,
Yeah, so right now it's not really accessible to get that type of imaging. So in the research realm, we have that imaging, and we're starting to show correlations and associations more and more and more. I tell people often, it's like when genetics first arose. When genetics first arose, it wasn't very helpful, right? Unless you had very specific gene problems, it wasn't helpful because we didn't have a library. We didn't have a library of all the normal genetics related to how people were and we're still building libraries about the abnormalities in the genome. So, genetic testing when it first came out was not very helpful. It's increasingly helpful the more we build our libraries. So right now, fMRI is kind of like in that state, fMRI and the other functional imaging. We need to build our libraries of normals. We need to then build our libraries of abnormals. And then only when you have enough, you can compare and pick this out. So right now, fMRI is mostly in the research phase in terms of wide availability to the public. However, you can go to certain centers, pay out of pocket, get fMRIs, and it can be interpreted. And those interpretations are done by certain specialists. So right now it's kind of almost not accessible, especially in Canada. I can't speak too much to the US, but you don't necessarily need it. So as a neurologist who specializes in FND, there are elements of the history and there are elements of the physical examination. So I can do examination maneuvers that will isolate and test the functional component of the nervous system. And I can separate that out from a structural phenomenon by the way an arm is held, by the way an arm moves, by what people do. So one thing, this actually might be a neat thing, because you can do this in a conference, and I could do it now with voice, right? Joe, you were there, you heard me say this. So Natasha, I'll do it with you. If you're sitting in a chair, you put your feet on legs on the ground, right? Okay, so both feet on the ground. And then put your hands on your thighs. So everybody at home who's listening can kind of do this too, right? Now, if you lift up your right leg, okay, lift at your hip. So lift it up, like lift your foot off the ground, right?
Yeah.
Right? Hold, right? What's happening on the left side? Do you feel the contraction of the muscles on the left side?
In like your glute?
Yeah, what's happening to it? So as you lift your right leg up, where's your left leg going?
Down.
Exactly. You have no control over that. That's functional system. That's function. That just happens. It allows you to sit, it allows you to maintain a sitting posture, right? So what we can do with people is I can say to people, okay, to try to push your left leg down, and somebody who comes in with a paralyzed leg, right? And they can't. They try, they can't. But then I say, okay, lift up your right leg, and likewise, I try to like lift up their left leg, and I can't, because their left leg goes down while the right leg's going up. But they don't know they're doing that. So it tells me that the structures are intact. It's their function that's off. As long as you distract them out of it, the automatic processes are all still there. So that's called Huber's sign. And that's almost a 100% specific and sensitive sign for FND. So if you see that, that's a person who has FND. It's a disruption of the functional system, not the structural system. You don't need special tests to find FND. You can do stuff like that. And there's a whole host of maneuvers that allow you to diagnose it.
So this is the interesting part, is like, okay, so now we're like in the software side of it, right? This idea that there's some malleability, like this is the structure still intact. If we could somehow support the function in some kind of way to get the function to come back online or to be more healthier and intact. And so I think it was at the conference, one of the talks, I can't remember, but it was, I feel like that's where I saw this just recently, but there was somebody was presenting like a shell shock diagnosis of like PTSD back in World War II. It's like somebody had been through whatever they went through, and they had this big limp, from something. But the bones, everything was okay. Then they had some kind of healing process, and boom, they're back. They were able to use their legs normally again. So this idea of the different kinds of traumas, as an example, that could cause this disturbance, and then that disturbance somehow gets maintained in the software of the system for whatever reason, like we say, it's conditioned into that function or lack of function. And then it's like, okay, what is it possible to decondition that and bring that back? And so that's trauma, and even blurs into like, emotional trauma and all the ways you could respond. But even like a more direct, concrete example for people to relate to, I think, is the post-concussive like headache, so that system dysfunction from that, I've run into friends and they have some headache problem that started when they hit themselves, and now the slightest hit and they get this really terrible headache and it's out of control, and get over it, it's in your head, why can't you get over it? And you mentioned a case like that when we were talking, and I'm curious about that example. Like, what have you seen, or how does this work in application there?
Yeah, so that group of patients is probably 50% of the patients I see at this point in time. These are patients who have had concussion injuries, who then have symptoms beyond 6 months, 1 year, 2 years, 3 years. I've seen people with symptoms for 15 to 20 years following. And then you do all the tests, MRIs and scans, and everything's normal, right? Yet they are very symptomatic. And they have a variety of different symptoms. It can be headache, but it can be a variety of sensory perceptual symptoms, light sensitivity, sound sensitivity, balance problems, they have emotional dysregulation, they have cognitive dysfunction, they have sleep dysregulation, chronic pain, be it head, neck, back. This is a very typical cohort. So these are called persisting symptoms after concussion. Used to be called post-concussion syndrome, but we don't use that anymore. Even the people in the concussion space recognize that this doesn't make any sense. So for me, it finally clicked that it's just that it's FND. Like, that's what this is. It's a disruption in the software, as you put it, Joe, and we talked about this, right? But it emerges out of the initial head injury. And how might that be the case? Well, when we kind of go back and say, well, if FND is a brain network abnormality phenomenon, right? Well, what happens in a concussion injury is you have a shock wave that moves through the brain, and that shock wave disrupts brain function at that moment. And you get a stretching of the cells, and you get a dysregulation of the cellular response. And we know this well. This is well documented in rats, and we've done lots of experiments here. But that quickly re-regulates itself, and 70 to 90% of people in 3 weeks go back to totally normal. But 10 to 30% in the studies persist with symptoms. So when I talk to patients about this, I say, look, okay, this is how the brain is organized. Fundamentally, at the basis, we have neurons and cells. Cells clump together in regions of our brain to form special functions, like there's a hand area, there's a vision area. But then the regions at a higher level work together to form the networks. And that's what we've been talking about. So when you get a collapse or dysregulation of the cells at the base level, right, you also dysregulate higher up on the chain the brain networks. They become abnormally connected because you've dysregulated their fundamental structure, the cells, right? But then the brain goes and repairs the cells, but in doing so, it can have a hypercompensatory response. It overshoots kind of and re-networks itself in a way that is abnormal. And so the symptoms persist. So what happens is, from the concussion injury emerges this secondary phenomenon as a consequence of the concussion, which is a disruption of the brain networks. And disruption of brain networks that persist is called FND. Very much like if I broke my leg and I had knee pain, I would get knee pain due to the fracture at the time of breaking my leg. But 9 months later, I still have knee pain despite my fracture being totally healed. I look on the x-ray, all the imaging is normal, everything. What's happening there? Well, as a consequence of the fracture, arthritis in my knee has emerged. So now I have arthritis. That's the problem, not a fracture. Likewise, FND is the problem in these people, not concussion anymore. So we have to reorganize and we have to focus our treatment towards FND and towards a persistent brain network problem. And then it explains everything. If you take that perspective, every single symptom of these mysterious people, which we can't even name, and we've lost the name of, post-concussion syndrome has become just persisting symptoms after concussion, which is a description, not really a diagnosis. They're not a mystery anymore. Every single symptom makes sense because every single symptom comes from or can be explained by brain network dysfunction, including chronic pain, like chronic headaches.
And could you now bring in how the psychedelic-assisted therapy has then been able to help in some of these areas from your neurological perspective? And also, like Joe mentioned earlier, like, what have you been seeing with ketamine, and what does this mean for the field going forward?
Yeah, so if that's the case, if everybody's followed me and we can come to some agreement that there's brain network dysfunction as a consequence of concussion, well, the science around psychedelics, the neuroscience with psychedelics, it's not debated that psychedelics disrupt brain networks. So they essentially collapse networks is the way you can think about it. Or you can think about brain networks as being specifically oriented in a certain way to give us our conscious, normal waking experience. When the networks collapse, this is what the psychedelic experience is like. This is why something like a thought can have a blueness to it. A smell can have an orange appearance to it, right? And so all our senses all intermixed, like that's synesthesia, for example. This is the collapse of brain networks because normally these things are separated out. So what we see in FND is that's exactly what these are. They're rigid patterns of the brain's perceptions. So Somebody in the context will come back to the post-concussion people as an example. They have light sensitivity. So I often say to patients, well, since your concussion, did the sun get brighter? Did lights in a room get brighter? Your eyes are fine. We've tested your eyes. We've looked at your brain, the pathway towards the back of the brain. So your eyes are okay. Your brain is okay. And the sun didn't get any brighter, yet you perceive light as being stronger. So the brain is locked into this state of perceiving light is brighter than it is, perceiving sound is bigger than it is, perceiving small pain is bigger than it is. It's a disruption in perception, which is a disruption in the configuration of the networks. So if you can collapse those networks in the context of psychedelics and then support people with proper therapy, because a lot of these people have had brain injuries due to pretty significant traumatic experiences or have had predisposing traumatic experiences, and a concussion can be a trigger reminder, and it can be the precipitating event. If you can collapse those brain networks and have the proper container of therapy around this for people to understand how to do it, you essentially can help these people reconfigure their perception. And that's what we're doing with FND. So we've had multiple cases of people. We've treated over 50 people, and a chunk of those were people who had FND as a result of post-concussion. Quite miraculous results. So sometimes people will develop functional seizures following a head injury, and as they develop FND. We've had cases where people who've had seizures for years after ketamine-assisted therapy go to almost zero seizures, sustained. One case in particular, which we published on as a case report, was not due to head injury, but due to a history of significant trauma in this woman who was in her 50s, who had 5 years of 2 to 3 hour plus seizures per day for 5 years, and was essentially not functional. And after 3 ketamine treatments, in ketamine-assisted therapy, not ketamine alone, ketamine-assisted therapy with ongoing therapy and some weaning maintenance over the course of 9 months, we heard from her a few months ago, 2.5 years later, at that point in time, was having about 1 seizure a month. Mostly she could stop them from happening. So another kind of remarkable cases that really continue to tell me that we're on the right path on the neurology side.
In this case that you're talking about wasn't from direct trauma, physical trauma. You're saying like some kind of like heavy accumulating trauma that somehow the person ends up overwhelmed. And this idea of, like, as you said, the neuroscience is focusing on networks, so the default mode network as one of these networks in the brain that, like you said, it plays a big role in our perception and our consciousness. And the idea that that there'd be some kind of like scarring or overcorrection or all these different things that could happen in the same way, like you have, you talked about the bone fracture. We could say like a keloid scar, here's somebody that has a wound, they get cut and their body's healing, but their healing is a little bit overkill and it turns into this thing. And now they have this dysfunctional issue in their skin. And so then that lingers. But in this other case where it's a little more potentially malleable, I mean, there is physical, there's neurons and the way they're organized and the way they're networking, and there's some restructuring that's participating in this shift. But in the default mode network discussion with the neuroscientists, they're like, well, these people that are depressed or they're anxious, they're in this narrow, rigid, kind of overthinking, trapped in this certain kind of perception. And they say, when you can tell the connectivity in their default mode network, I mean, like you said, it's in its infancy, right? We're not ready to just look at functional MRI and say, oh, this person they're thinking about this too much, but they're seeing these patterns. We're learning about this library of patterns of like, hey, that person's functioning, like I would say, trapped in their head, and they've been kind of scarred into that. And so, one of the ideas from the shamanic work or other kinds of approaches that, the system's overwhelmed. It needs to just shut off circuits, numb out, disconnect. And there's all these different ways that would influence. So this idea of like scarring of the network, like scarred from trauma. And then you collapse the network. And a lot of times you see all this emotional content come forward. Sometimes repressed memories come forward, things that were being like held down somehow in the system. And I just think it's really interesting your approach with that and how it's going to blur over this interface between neurology and psychiatry and psychology that's been kind of waiting to happen, Like in the Fellowship of the River, in my book, I go to medical school, go to the clinic. I don't feel well. Well, it's just in your head, So there's we used to say it's just in your head. But how come we never talk to the neurologist? Like we should have just asked them. We didn't have the technology, I guess, to assess this subtlety, but we're getting there. Just one more thing. I'm throwing a lot of things at you, but this is the question. Here's the question. There's a clinic here that's like an infusion ketamine clinic that doesn't even do therapy. Now they're doing therapy a little bit. That was anesthesiologists that are running a place. And they were getting a lot of firefighters coming with, some of them with TBI, traumatic brain injury type stuff. And like, oh yeah, we're starting to treat these firefighters. I'm like, well, what are you helping them with? Was it just the physical, the pain? He says, no, it's PTSD. Like we're helping them with the PTSD. So when you see it blur over, and you mentioned this a little bit, like, how are people coming to your clinic? Because they're like, actually, what about this? Do you think you could help me with this? That isn't necessarily, seizure or headache, but I heard you helped somebody with this, and now we'd like to try it.
Yeah, so you were tons of good points there and stuff to chat about. Just to kind of mention the case we initially talked about, yes, it was complex PTSD. So this was a woman who had childhood trauma, and it was a very, very complicated trauma and complicated life. So that's all kind of detailed in the case report that we published. I'm happy to share with you both after and for the audience. But kind of back to what you said, for me, neurology and psychology or psychiatry doesn't exist anymore. So I actually don't even like using the words. I get it, we have to box this up. I just call them brain-based conditions. It's all brain-based. I think separating out into neurology and psychology is a relic of the 1800s. From, the famous case of Phineas Gage, this is where localization started. This is a railroad worker who had a spike through his head, and then he had a very distinct change in his personality, and it was kind of predicted what would happen. He was alive for a while, and when they did an autopsy on his brain, they saw certain centers of the brain were impacted. And this kind of was like the birth of neurology, where it became like certain parts of the brain caused, are responsible for a certain function, and that was it. The brain doctors who believed that model separated off and became the neurologists, and all the other ones left over became psychologists and psychiatrists. And so you had this separation that occurred in the 1800s. And what I think is so beautiful about psychedelics, I do think psychedelics will be the tool that will bridge neurology and psychology again, because this is that overlap that happens. You can't separate them out. They intermix into each other. And so when I see patients, there isn't a single patient that I see now that I believe you can parse into neurology, a neurological patient and a psychological patient. And so I, in this work, will only work with psychologists at all times, and would never give somebody ketamine as an infusion and just leave them, for instance, and not have therapy as part of their process. It just doesn't make any sense to me, I think, at all, in any model whatsoever, when you're kind of actively going at some of the conditions we talked about today. So I guess by virtue of that, Joe, yeah, people are coming to me now more about kind of treatment for my brain-based condition rather than just as a neurological issue. People are coming because they have, maybe something that would be dubbed neurological, but also have PTSD or also have significant depression or significant OCD. And having paired up with the two wonderful psychologists that I'm working with for our new program, which is Homeward Therapy, I now feel equipped that we together can help these people. And it really makes for unbelievably meaningful work from my point of view with that lens. It's inspired me and changed how, going into kind of the second half of my career, I guess, over the next couple of decades, I'm thrilled to do this. It's such a neat window on what was previously a very kind of isolated field that I came out of. Looking back, I don't think I could just be like a quote pure neurologist again. I couldn't do it.
But it's so great that you are a neurologist and the pediatric neurologist to have this background to bring to it. I mean, this is some big missing pieces, I think, to when we're just hearing from the psychonauts or these people or those people. It's like, no, this is just like it's coming through the clinic right here. We're trying to help these people. It's
like it's a brain-based condition. So when I teach to the residents, I'm like, guys, the field is wide open for neurology. Like, this is it. There's so much here for us to learn. Like, I've learned so much from the psychologists, but also for us to share. And that perspective, and Joe, I honestly think that's like when you and I connected in the car, it was
Yeah.
a lot like I loved hearing your perspectives on the
Yeah.
shamanism around because it intersects, and then I'm thinking and conceiving of it from the neurological side, and it just creates such a much more elegant, complete model in my mind. It's really it's so exciting.
I have a couple of things to add here. And throughout the conversation, we've been speaking about psychedelics loosening up the kind of rigid brain networks, also kind of this constrained state getting shifted, and it can help with the re-networking of the brain and perhaps with rumination. You mentioned OCD as well, which is also something that I have personally struggled with in the past. And I think that it's really interesting because my experience with psychedelics hasn't always been that. Sometimes I feel that it heightens the rumination. And I feel, well, my question is like, what do you think might be going on here? What would you say to the people who are finding that actually the treatments are causing kind of a heightened kind of rumination? And the kind of real question that brings us all together is how are you deciding for which patients this is going to work for, right?
Yeah, that's such an important point, Natasha, because we've been speaking to a lot of the positives of this, but I do see a lot of negatives from psychedelic treatments, and so I do. A portion of my practice is psychedelic harm, right? People who have gone off and done psychedelics and have been involved in certain psychedelic experiences, have been with physicians in ketamine clinics, and come back worse than they were before. In some of these cases, they had FND and the FND exacerbated, or they developed FND as a consequence of their psychedelic harm of their experience. So this is why it's so important for this to be multidisciplinary. You've got to have the right people with the right lens working together with these cases, in my opinion, because a lot of these situations can be really complex. And to come back to this model we've been talking about throughout this conversation, right? If you are a person who has a condition with significant rumination or constrained cognitive constraint where you're inflexible, right? That's the problem. And you're kind of stuck. And you can conceive of that as the networks being rigid and hyper-connected. And so at that moment, right, before you do the psychedelic experience, your networks are set up as such. Your behavior, thoughts, rumination, whatever you might call it, is set up as such because all of that has been created as a stabilizing force against something that caused you to be there in the first place. So even as bad as one feels in that moment, you're like that for a reason. There's reasons there. And you're in that state is because you're alive, you're stable. Right? By virtue, it might not feel good. I'm not saying it feels good, but you're stable. So your brain, from a neurology point of view, your brain has configured itself, right, in the most possible stable state it can, given all of your experiences up until that point. Okay. So that means the kind of worse you are, the more important it is to maintain that, right? So now you go into a psychedelic experience and you collapse that state. As the psychedelic wears off, where is the brain going to go? It's going to go right back to where it was because it was so energetically important for it to be in that state because it was keeping you alive, whatever that state might be. So it's going to try its hardest to go back into that state. And this is the therapy. The therapy has to come in and help guide the reconfiguration because without the therapy, without the guidance, without the support, your brain will go right back to where it was. And in fact, because you collapsed it, it actually might go back even stronger. It might double down on what it was before. And this literally can be conceived of from a brain network mechanics point of view, that it's going to go back to the path of least resistance, which was the path the brain carved out for you in the first place. Not that it was healthy. It was a maladaptive compensation overall, but that maladaptive compensatory state was keeping you alive. And so this is why after psychedelics, people can become very destabilized if they don't go back to how they were before. And I've seen this in individuals who suddenly kind of feel better and their brain doesn't know what to do with feeling better.
Yes.
And it destabilizes them and they go through a period of significant anxiety. And now they have this whole other condition. So this is where I think in kind of the anecdote you shared here, right, is you've got to be really careful, ensuring you have the right preparation, you have the right supports through a process, and you have the right supports afterwards. Because if you don't, I do worry that you can make yourself worse. And it does kind of worry me a little bit with how accessible psychedelics are becoming, because I worry about that as being a problem en masse in the public, that people are just going to go kind of do it and not have the right container thereafter to support kind of the reemergence out of a psychedelic state. I'm pretty passionate about this part of work now that I've been in the space for a long time.
Yeah, I think it's that. Okay, so this system dysfunction, disruption, I like that. It's going to
Yeah.
disrupt the network, right? So if we're disrupting the network, and then the network needs to reconfigure to get back to, in other words, let's say the person has a system issue with their leg movement and they're okay, and can we use the ketamine or something like that to open up the network, and also open up the neuroplasticity to allow for this thing to come back online? And what's the right physical therapy, or what is the right kind of thing that the person needs to get them to grow in this certain kind of way? Just as you said, the kids that are seizing through these like windows of development, it's like, oh, this is a big problem. We're not going to get this back. They're gonna miss this window. So now we're reopening a critical period. But then it's not as simple, like we can overly, like you said, simplify it or reduce it down to, oh, it's just the neurology, but it's not the rest. But it's like, well, actually the rest is there. It's like, it's the life. So how do you get them to flow and grow into this healthy? So you're saying, okay, the right kind of psychology support, the right kind of responsible medical intervention that's going to say, whoa, this can go wrong. Hey, don't overdo it. Hey, let's be careful. And then I think that's the art of it. And we get back to that. There is an art to this. It's a related art to, raising a child. It's like, it's not as simple as if you just do this or do that. It's like, there's a whole art. This is a living being, and that's a reality. So we're going to try to deal with this interdisciplinary, multifactorial the best we can. And I think that's what's so interesting. Natasha's talking about examples of having a bad, even with ketamine. A friend of mine that went for infusion therapy had a nightmare experience that opened up all this stuff, no support, feels more depressed than ever leaving that place, but somehow might meet someone that guides them, why don't we try it this way? And then has a huge shift. So obviously it's not just what you do, it's how you do it. And that's the art of this, that I'm into it from the ceremonial of like drawing on that background, right? All the shamans and everybody through time. That's like different ways of like, how do you hold the space for them to grow back into a healthier function? And I mean, it seems like that's what you're focused on, and that's what you're doing, and seeing that potential. And to me, that's the spirit of your story. It's like, okay, wow, this kid that wasn't getting any better at all, zero. And then you find out, what? Like, you could help him. It's like, oh my God. So then this hope of like, can we be more effective? And it's like, oh, wow, being more effective is about learning. And it's a normal stage of like growth of a field. I think it's like the anatomical, the concrete, and then you get into the functional. It's like, you build the guitar, and it's like, oh, wow, we built it. And then somebody's like, whoa, look what you can do. Well, they can do a lot with this guitar. So it's that development into that direction. It's like, okay, we want to help the people. And so if we learn about systems and then this disrupting networks, but also like guiding the healing of that network, and how can we be more effective, which is good, of course, for patient care. And ultimately, I think economically, it's the sound plan for doctors. It's like, if you're getting better results, that's wise. I don't know. I just want to just salute you for your pioneering kind of attitude.
Thanks, Joe. Thanks. Appreciate that. I love that guitar metaphor. That's a beautiful metaphor. That's great. As you said that, I was imagining these like the first humans to make like a guitar-like instrument, but then it's like how you pluck the strings.
Right.
If someone shows you how to pluck the strings differently on the same structure-based instrument, it's going to sound differently, right? So that's a beautiful metaphor.
And it could be beyond your imagination, right? And so that's the piece to keep alive.
Yeah, I love that.
There are things that you have not imagined, and somebody's going to sit down and show you, oh my God, whoa, I had no idea you could do that with a guitar. Cool. And like, that was my interest with genetics. You brought up that example, genetics. It's like, okay, the DNA code, and we're like, okay, we got the code. Perfect. And now they're like, oh, it's the epigenetics too, like the
Mhm.
software. How do you express the
A whole
code? Turns
other
out that's a
layer.
whole other layer of complexity. And it's so complex that the art of it starts coming back into it again.
I think also just like on that whole point with safety, and maybe we can kind of bring it to a close, but with advice for practitioners and other people who are really interested in this space, because I know I've heard you speaking, Evan, on other podcasts as well about developing like standardized protocols and what you did at the Neurology Center and all of that. Like, I don't know, Joe, is that something that you think would be interesting?
I think it's important. It's in development, but we need to talk about harm reduction.
Mhm.
You know, we need to be responsible. We have to handle very carefully. And so there's no question about that. I think that making things more available
Yeah.
and the way it is, I think it's a learning curve that we have to go down. You know, with cannabis, maybe just a side note, I know, cannabis where they're making it so strong and the legal cannabis and they're just competing to make it so now you're getting these kind of cannabis OD. And so it's like, does it need to be regulated around the strength of what's available and what people can access, like alcohol?
Mm.
Well, yeah, I think that's reasonable. That being said, with those examples out there, do I think it's just to have put so many people away in prison for cannabis? No. And so I get that the fear, we have to be careful, of course, but they're out there. And I think the youth have pretty wide access to psychedelics. I don't see a lot of anything slowing that down at the festivals or wherever. So then, the risks, they're there. We need to be aware. And I think getting the medical field involved as we move towards a more legal landscape, it has a great opportunity to move towards the harm reduction. Keeping it illegal, and now they don't even let the doctors, explore the cannabis oils and write the book to explore the dosages. And you just have these guys, we're leaving it to the stoners, no offense, to Cheech and Chong to help us figure out what's the right one for this cancer or for this seizure. It's like we kind of have to bring it into the mainstream to share the knowledge.
Yeah, that's a great last point. I mean, that was the impetus for me conceiving the cannabis dosing textbook that we just published, because at the stage at which I was doing this, I was having patients come to me and everybody was on something different. And I would say, well, where did you get that information from? Oh, I got off a website. Where'd you get that information from? Oh, I went to the store and the guy told me. So I mean, you've got like a 20-year-old kid who took a course on cannabis over the weekend and is now like a bud tender telling a parent how to treat their child's complex epilepsy, right? The only reason that was happening, to the point that we made today, was because the neurologists were putting their head in the sand, pretending that like it's not happening, when it's like it's so easy to get in Canada. Everybody's getting it. Like, this is a joke. So this is where I mentioned earlier in the podcast, but it really developed my harm reduction perspective in medicine. I was like, look, if they're going to do it anyway, these parents are desperate. They're going to go get it and give it to their kid. If it's not me helping them as an epilepsy specialist, right? And it's not the guy next to me or the woman next to me, the other neurologist, who's helping these people. So for me, that was a big reason why I went into broader cannabis treatment for kids with epilepsy and others. But then also why I wrote the book too, because we need to have some standards when these things are so widely available. If they weren't widely available and it wasn't easy to get, and you can wait, you don't need it. So this comes back to psychedelics. So I worry about the accessibility because of the lack of education in the medical system. So when if we as doctors are not even learning about this stuff, again, burying our head in the sands, like this isn't out there and it's not accessible, then when the kid shows up with serotonin syndrome from MDMA being at a rave in the clinic, how quickly are you going to know that? If if a kid comes into your practice or an adult comes into your practice and says, I really want to go do MDMA at this, this party next weekend. What do you think, doc? And you're like, no, don't do MDMA. You shouldn't do it. Like, it's bad for you. It's going to cause brain. Like, it's such a ridiculous answer to say to people because they're going to do it anyway. And here you have an opportunity to properly educate that person, right? Like, make sure you have enough water. Make sure you have friends that you're going with. Make sure you have a ride home. Like, there's so much prevention we can do because they're going to do it anyway. And so this is where, from the neurology point of view, and maybe I'll just tell you this one quick thing. So another really important case that we came across, but also a phenomenon I came across, is people with spinal cord injury who do serotonergic psychedelics. Right? We wrote a paper on this because I started getting asked, why do people who have spinal cord injury have such intense muscle cramping? And I was like, what are you talking about? Never heard about this before. So we went on Reddit, and there are hundreds of individuals talking about the same phenomenon. They do a small dose of serotonergic psychedelics, so it could be MDMA as well, and they have these unbelievable, profound changes in temperature, so hyperthermia, sweating, muscle contraction, and you start thinking like, oh my God, these people are having serotonin syndrome, but they're getting it from like 2 grams of mushrooms, where that would be almost impossible for anybody else. Why? Well, they have a severed spinal cord. The severed spinal cord causes neurologic changes at the level of the spinal cord, which upregulates their serotonin receptors peripherally. And they get this like peripheral serotonin syndrome without the central psychedelic effects. So they get these really, really horrible side effects. One case that we're reporting on, a person was in the ICU for 7 days after taking equivalent of 3.5 grams of mushrooms. Okay, so the problem is if that person comes into the emergency department as a neurologist who doesn't know anything about psychedelics, you're going to have no idea what's going on here. So we're not ready from an education point of view for these to really be widespread around the system. It's not protocols, it's like ground roots medical education. We have to teach people. The doctors need to know about this stuff. Doesn't mean you have to prescribe, but you got to know it and understand it because it's here. So that's to Natasha, to kind of speak to the last point there. That's the big emphasis I have with safety, is that we need to bolster the from the medical education point of view. It has to be instituted into curriculum, and it's got to be well understood. It's all pharmacology, and we know this. It's not mysterious, like it really isn't.
Thank you so much for your time and for sharing all of that just extensive knowledge with us. Honestly, so grateful. And I guess just if there's just any like research we should be keeping an eye out for, or if there's any like upcoming projects that you'd like the audience to know about.
Yeah, thanks, Tasha. So we're opening up Homeward therapy. We're gonna probably treat our first patient in January, and that's gonna be a ketamine assisted therapy and psychedelic assisted therapy program in Toronto. And the biggest thing we want to do is we got 2 groups we're going to study and publish on. We want to publish on 10 cases of functional seizures and 10 cases of FND emerging out of concussion injuries, because there's really no data. There's no clinical data in the literature. So those are the kind of 2 exciting kind of research projects that's going to get integrated into the program. So we're really thrilled about that, and to add to the clinical base in this condition, because it's coming. It's coming.
Thank you for joining us for today's discussion with Dr. Evan Lewis. Please see the show notes to find links to his YouTube and various websites where you can learn more about his work. You'll also find information about the newly published textbook he helped edit and conceive. If you enjoyed this podcast, please hit follow so you never miss another episode. And if you'd like to stay more connected, Dr. Joe Tafur has a monthly newsletter and Patreon call, which you can find in the show notes. At Modern Spirit, we also receive donations to help provide scholarships for people to join our retreats, courses, and events. Remember, if you have any questions, comments, or topic suggestions for future guests, feel free to reach out to info@modernspirit.com. Thank you so much.